guys. I appreciate the opportunity to visit with you guys this morning. I like to say that I got started in the field of disaster mental health by just being an innocent bystander. If you want to go to the next slide. So this is Hurricane Katrina, a day before it hit landfall, and at the time I was clinical director and still am of Mercy Family Center, which is a outreach ministry of the larger Mercy Health System based in St. Louis, and also survivor. My house that I'm standing in right now had 1 foot 7 inches of water underneath, and I was in a disaster area. But at the same time, I was called to the Department of Education, state of Louisiana, to have a discussion about what would be best to serve kids when we all got back in town. Next slide, please. And Project Fleur-de-Lis was really a product of that conversation. Project Fleur-de-Lis is a funded National Child Traumatic Stress Network member through SAMHSA. We've been funded since 2008. And our programming throughout the years have focused primarily on disaster response, but sadly in New Orleans, our second grant has been focused more on community violence. Next slide, please. And you can see here the large network that we have within the National Child Traumatic Stress Network, and Betty's group is involved out of Oklahoma, and Bellevue as well is represented up in New York State. Next slide, please. So in looking at distinguishing features, what I call the signature of events, we like to consider the location of the event, where it is in proximity to the population, is it rural or urban, time and duration, the magnitude of the event, the impact relative to the size of the community, and I think Joplin is a good example of that. The cause of the event, be it man-made or natural, and we'll discuss that, give you some very concrete examples. Finally, the level of exposure, including secondary exposures, significant losses, and were there any unique features of the event itself. Next slide, please. So over the years, Project Fleur-de-Lis has become a local, regional, and even national trainer in evidence-based practices, looking at immediate practical help, intermediate, what we call resiliency education, and then the higher levels of care, which are really more formal therapies focused on immediate group treatment and long-term individual treatment. And in Betty's talk, she talked and spoke of the stepped approach, and this is an example of what the stepped approach can look like in communities after disasters, where down below in the green sections you have practical help and education for all individuals exposed, whereas at the upper levels, as you work up and in some ways triage, find out who needs this more formal therapy, you can provide some levels of group treatment and long-term individual treatment. And although we focus primarily on children, the interventions that we've helped launch have focused both on children and families. Next slide, please. So here is a list of what we call a tiered model of care for children and adolescents, looking at psychological first aid at the first level, skills for psychological recovery, above in the more formal treatment areas, something called cognitive behavioral intervention for trauma in schools, which is a group therapy launched in schools, and finally an individual treatment, trauma-focused cognitive behavioral therapy. And all of these listed on this slide are either evidence-informed or evidence-based treatments. And what I'd like to do, next slide please, is to click it through here. There's a timeline off to the left, and you'll see here that, like I said, immediate care comes by way of psychological first aid. There are a couple versions of these. The one that we embrace is co-written by the National Child Traumatic Stress Network and the National Center for PTSD. And the 3-month SPR, I'll focus on in a moment, and up and on through past 3 months. Next slide, please. Central concepts. I'm going to drill down these to the green level because in my experience of the past several years, I find the most traction and the most focus or in some ways bang for your buck, is around these two levels of intervention. The idea being, if you can get people where they are immediately through something like psychological first aid, whether that's first responders, people in shelters, or going door to door through a crisis counseling program, you're able to forego or in some ways interrupt some type of higher level need in mental health care later on. Skills for Psychological Recovery is a longer term program that's generally launched and looked at as a one-year plus program to, in a lot of ways, what I would say, reinforce resiliency, not so much teach it. Next slide, please. And the concepts around, you'll see, I think, a small block rising. It's from Hobfall's paper, which I provided to the group, looks at safety, calming, connectedness, self and community efficacy, and hope. And these are the core kind of tenets that drive both TFA and SPR. The core concept, next slide, for the higher level comes by way of, if you click again, I think there's a block that comes up that shows the trauma narrative. And the trauma narrative, this is, again, formal treatment, and it's evidence-based practices where kids tell their stories in a very controlled and manualized treatment with good outcomes. Moving on, again, tiered model of care. I'm going to go back and drill down some very concrete examples in the community where these were launched. Moving on to psychological first aid, you'll see a slide. There again, it's a product of the National Center for PTSD and the National Child Traumatic Stress Network, funded by SAMHSA. And the key point here, next slide, you'll see at the top, what are the basic objectives of psychological first aid? This is actually taken from an adaptation of psychological first aid for schools, which was launched post-Sandy Hook as a way to modify some of the basic techniques in psychological first aid. If you click again, the main takeaway from this slide is a yellow circle. It's practical assistance and information. It's getting people what they need in the here and now. So whether that's information about the disaster, whether it's a blanket or whether it's a glass of water, it's information and practical assistance to help people navigate emotionally and intellectually the first 3 to 6 months of any disaster in a way that's meaningful and gets them the help that they need. Next slide. Skills for Psychological Recovery is really a resiliency-based program, again, authored by the National Center and the National Child Traumatic Stress Network. We've gotten a lot of traction, so to speak, with this program across the United States. Skills for Psychological Recovery really comes in, next slide please, say after psychological first aid, to not only speed up recovery, but again prevent the mental health problems, support functioning, and prevent behaviors that may make things worse. I like to look at skills for psychological recovery as reinforcing resiliency, knowing that most communities, most individuals are resilient upon themselves, but the disorienting, I guess is the word, the frenetic lifestyle that we all lead in a disaster zone, we forget these things. And so SPR may teach skills such as problem solving, managing reactions, social connectedness, and this program is held in high regard across the U.S. as a more intermediate program. Next slide, please. So let's look at how SPR was used in southeast Louisiana. So April 20th, 2010, the Deepwater Horizon platform exploded, and through the entire summer we watched that camera with the millions of barrels of oil being dumped out into the Gulf of Mexico. In the end, when it was capped on September 19th, an estimated 4.9 million barrels of oil were dumped into the Gulf. Sadly, not only certainly a environmental disaster, infecting not only our coastline and ecosystem, but it was a huge financial disaster for our area. And we were asked through a coordinated effort with Catholic Charities in BP money to evoke a SPR program in southeast Louisiana. Next slide, please. And we called it Mercy Community Hope Project. And next slide, please. And you can see this slide of southeast Louisiana. The stars represent towns in which we were able to launch SPR, both for children and adults. In the end, we primarily served children because of access issues, knowing that schools where kids can be easily accessible. As far down as Chauvin, Dulac, working very closely with the Homa Indian Nation, all the way up into places of New Orleans, Slidell, and even Covington, north of Lake Pontchartrain. We were able to impact children. Next slide, please. So in the end, we had 10 sites. In the fall of 2012, we were able to serve 222 children, and in the spring, 197. In the end, we were able to serve 419 in that school year. And again, what's nice about this is that we only used 3 FTEs, 1 intern, and 1 school counselor. So we think that the impact here was pretty broad given the number of people that we utilized. Next slide. Here's the signature literally in Joplin. You can see the scar that EF5 tornado left in the afternoon, Sunday afternoon, May 22nd, 2011. The stars that you see there are schools and a community center. The green are schools and 2 are community centers where we were asked to come in to work with the larger Mercy to develop programming in the area. We entered in the fall of 2011 and through focus groups decided that SPR would be best provided in a larger group setting. We knew at the time and through the focus groups that people were gathering for potluck dinners, and the sense of community and resiliency in Joplin was extremely strong. So we built SPR around these community dinners and got funding for that. And we're able to launch a large project focused on teaching resiliency across the community at these community dinners, which happened about every other week. Next slide, please. And on to, you should say, Mercy Community Connections Outcome Data. So the scope of this this project was huge. Over 8,000 people were served dinners, but every single one of those interactions were documented and down to about 4,000. So the workers, the caseworkers that were at the dinners would rotate and sit and talk with people and offer instruction in modules of SPR, be it managing reactions, problem solving. Senior Connections, 1,227. I think the presenter is it Lisa. Later we'll talk about her work with SPR in Joplin as well. Internally within Mercy, we were able to use it for many of our coworkers up there, and provide some other community connections and some resiliency classes as well, kind of a higher level of service. Next slide, please. This is Hurricane Sandy. This is on the, I believe, on the 25th as it's passing Florida. It made landfall up in New Jersey on the 29th, and we were asked to come in as trainers, both myself and Melissa Breimer from the National Center, to support their crisis counseling program in the state of New York. Next slide, please. And there's a program called Project Hope, and the challenge was around scale. Next slide, please. And we had 32 provider agencies, and with so many agencies and 700 crisis counselors, we developed a train the facilitator program by training the team leaders from all these agencies throughout the summer, and then having them go back to their own agencies and train their groups, and then launch this past fall. Next slide, please. Our success, SPR was implemented in all the 5 boroughs, including Long Island, out in Suffolk and Nassau counties, upstate counties of Westchester and Rockland. And throughout our time together was an extra focus on the Rockaways, that were hit especially hard. And the SPR programming is still going on. It's beginning to wind down right now in New York, and so we're proud of that success and be able to get this resiliency programming out to the community. Some recommendations: shortening the timeline for crisis counseling programs to receive training in resiliency programs like SPR would be helpful. You can see there the timeline. You know, for instance, Hurricane Sandy or Superstorm Sandy, there was a 7-month delay from landfall to us being there, and this comes not only from our level, but the caseworkers themselves saying, "If I wish I had this earlier." Now, I know that the crisis counseling programs have a lot of paperwork and other interventions that are necessary to meet their goals, and so SPR is layered on top of that. But again, it would be nice for them to receive this earlier. Second is to provide education to communities regarding best practices, what they are, what they're not, and how to best vet partnerships with outside organizations. In all the disasters that I've been invited to help respond to, we've seen carpetbagging, and a lot of organizations come in with not best practices and suck up resources, and in some ways prey upon community organizations like church groups, parishes, and sometimes their intentions may be the best, but what they provide is not best practices. Partnerships as well, and I'm putting universities on notice here as well. There's a large influx of individuals doing research, and we have to really be able to vet those and make sure that it's a win-win for both sides. So the recipient organization is not left with no resources after the research is done. And finally, building in what I call a one-year, one-day funding and recovery summit. I warn communities that I work in during the first year that after that first year is over, the media cameras and a lot of the funding is going to roll up and leave town. And so there is a clearly, if not a concrete resource departure, there's certainly an emotional letdown around entering in the second year of recovery. And so if there was some kind of hardwired program to build in some type of funding and certainly recovery summit to boost people's focus on the following years at that time, I think would be extremely helpful. Next slide. That's where to find me, and that's it for me.
Good job, and thank you very much, Doug. Let me start